to this conference, and I am in the 100 UCL University for a training, so I'm here for online connection. Some slides are some similar to Sinan-based presentation. I'll talk about when we say hypertension, it's a global problem. While we are having the hypertension, there are the life changes still going, and there needs to be some alternative methods for some patients. There's a reason of this based on this, of course. There are the systems that the side effects and or the patient doesn't want to take the drugs. When we say hypertension, we think we can solve everything with the medication, but the compliance to the drug is very low, and we observe this. And most of the drugs that we have, we recommend to patients are not taken. RDN is a very good alternative in this regard. And the new position papers, as they will be explained, this is an alternative treatment for the patient, a supportive treatment to the patient. This is on our agenda. So we are thinking of RDN. What should we have in our toolbox? What should we have in the laboratory? So transcatheter, we need a 6 French sheet, and we need a 6 French guiding catheter. The guiding catheter can be 45 to 90 centimeters. E1, EMA, Lima, RDCN, and one RDCN1, and the RDC1 can be used. We use with a 0.14 guide wire. Nitrohydrophilic is preferred. The traumatic, there could be traumatic impacts and Y connector, and that we use in percutaneous. Standard percutaneous procedure and ionic contrast, and the isotonic set should be with heparin. This is what we deserve technically, and noting electrode, and this is spiral RDN catheter, multi-electrode RDN catheter, and for radio frequency, we need a generator, and we use simplicity G3 model is used. And when we look at the drugs, there's heparin, morphine, fentanyl, or the ones which will go for analgesia, and also for methadonalism, Barnicum, and with tranquilization, and atropine is a user should be ready for us, and because sometimes secondary to pain, there could be bradycardia that could be developed in the patients. So from past to future, when we see whether there are some changing concepts at the renal artery, nerves are known. In the past, we were trying to do that in the side branches, but we know that the renal sympathetic nerves are closer to wall. Also, the RDN procedure in this cell will have a more achievement and success rate compared to others. Theoretically, in vivo studies, as we can say. So from the main branch, or when there's a side branch, the combined treatment is the most important. And if there's an ablation of both branches, that is better. So our perspective has changed compared to future, and in the past, so we used the main branch only. Now we have this cell bifurcation we're trying to reach. So what is the multi-electrode catheter in this regard? So for example, in the HDN3 specific flex catheter was 4 mm, and for the veins above 4 mm. However, spiral is used for the veins of between 3 and 8 mm veins. So it is more flexible, and there's a multi-electrode system, and it could be used in the other the veins. That the new spiral is RDN catheter. makes it easier to ablate the other veins. So how to do it? There is a bit of 6 French sheet we enter, and we use a 6FA guiding catheter to renal arterium ostium. Of course, we have to look at the renal arterial limits with tomography, with an MRI, or with using catheter. You need to have a good imaging, because there could be accessory arteries. They should be selected before the procedure, and if there's an accessory renal artery with a good diameter, increases the success rate. With the guiding, certain guiding catheter, we use a 0.14 guide wire. We put the guide wire, and with through the guide wire of 1/4, we cross the spiral catheter. The stand marker should be put into here there, because when there could be foreshortening when you pull out the guide wire, and when you with the contrast, you can control it with 50 to 50, and then we pull back the 0.14 guide wire, and then of course we can see that all the electrodes, we assume that all the electrodes touch at the wall. We wanted to, before RDN, we have to be sure of that. So we look at the generator and we check some data there, and impedance is the one which sheds a light to our way. We look at impedance graphics and the respiratory cyclus. We see whether there's a change, whether there's a change or not, and this shows us whether if there's a huge waving, and if they're changing, and we can say that if it is minimum, the contact is better. So we are not happy with our place, let's say. So we have to position the catheter better. For that, we have to use a clockwise rotation. We have to, without torquing more than 180, we have to circle it, and we have to pull it upwards and downwards, and we can be pre-positioning without having a new guide wire. But if you want to have a more movement, and if you want to take it more to upwards and downwards, so you can use a guide wire support, and you can put it, push it to this, and you can position our. But the small movements can be used there in the clockwise rotation, and we can have it. If you are happy with our plans, we will decide whether we will activate all the electrodes. So we have to decide on this, and this cell when we start with, we want all the electrodes to be active to ostium. When we reposition, if there are electrodes there, we can touch it there, and we can deactivate the electrode. The electrodes, 4 of them can work together, or we can deactivate the ones that we want to deactivate. So in order to make it active, there are some options. You can hit the blue button in the generator automatically. If you have a foot pedal, you can use you can have the same system, and if you have a remote controller, you can push to RF, and after that the catheter should be kept fixed manner, and the algorithm works, and there's nothing that you have to do, but there are some data that we have to follow through the screen. For example, there is a blue graphic, shows the temperature, and we expected it increases. This is another indicator of the success of the procedure, the increase of the blue graphic, and there's the impedance is impedance in the white graphic, and we want the impedance to decrease, and one other parameter is the time, and the 60 seconds that will be filled slowly, and we will not touch the generator, and automatically it will make the procedure. If there's an anomaly, if there's an abnormality, the device closes itself down. If you manually wanted to intervene, you can use you can stop the ablation using the blue button in the with the foot pedal. This is the guiding catheter with 0.4 catheter. We make the crossing. We take out the guide wire, and the catheter has become in a spiral shape, and then you start ablation. You see simple stiff-lex catheter with one electrode, as you know. There was a procedure time was longer, and we couldn't reach the homogeneous parts that we wanted to reach. But a spiral catheter activates 4 electrodes, and then ablation is done in 4 systems, 4 points, and so we are using with a more flexible catheter. Is it safe? Yes. In 3-year follow-up from global simplicity registry, we can there is a decrease in the values, and we can say that in the low GFR patients, so there is no problem in the long term. When you look at all the data, we can say that there isn't you see that the negative events possibility is 0, and there are some complications, and in these complications are the complications that could easily be managed if there's going to be a stenting required, and of course you have to be ready for stenting as well, and the operator should have a renal procedure experience. I thank you very much for your kind attention. Thank you very much, Adbey. Any contribution from the panel? Any questions? Any contributions? Thank you very much. The impedance should, in order to leave active lesion, what should be the impedance? And there is no value in the graphic. You can see that the impedance should get lower than. So, of course, in order to have necrosis, there should be 10% decrease. Is it the case? What is the maximum level? Why should we stop? Impedance, let's say, decreases 15%. So, what is the level? How will be is cut the activation? So you don't have to do something special for that. The impedance, whether it is getting lower or getting higher, isn't an indicator for us. If you are not happy, so I'm in Japan. I couldn't hear you, sir. If we have coronary ablation and they are in the sinus, coronary sinus, it is a 10%, even if there is we experiences. I think that there is no limit right now in this studies for the renal artery wall thickness is not like a coronary sinus, so energy is the fixed energy. If the patient experiences pain, or if there's a decrease in the blood pressure, we walk, and I don't think that impedance can cause this. We should not stop the generator. If there is an abnormal situation or abnormal case, it will stop this. Actually, in the renal arteries, so that when we are denerving the nerves, as you know, around the renal artery, there isn't they do not they are different from the motor nerves. Our objective is to have a fixed impedance of value with the delta wave is not above 10%. Through 60 and 70 degrees, so we have to warm this place up, and to around the renal arteries. So the advantage and the fatty tissue that determines your impedance. If you use If you start with 240, you have to finish on 260. You can 260 or 280 ohm. So sometimes you start with the 300 ohms. So what is important is that if you start with the 300 ohms, when you warm this part, the impedance should be fixed, and 50, it should keep you in 60 seconds. It is different in coronary sinus. The fact that the graphic should be fixed, as I pointed out, if the impedance shows that we are fixed. So if you're in ablation, so of course you're having the pace as well. This through the sensing value, and if the impedance of value is there without pacing, if the impedance is changing, if it is between 500 to 1000, you have to change your place and you have to stabilize it in the renal arteries. This is what we are doing, and the ohms and the impedance should be fixed. It means that you can start warming up. So it is like a permission. I'd like to ask two questions. Do you understand that the procedure is effective? Do you see a decrease right away? How do you do the right and the left? You do it both sides. Is there a criteria there? Should we do it? How do you do it in both sides? This is what I wonder. I'd like this. So we have to apply the right and left arteries. If there's an accessory vein, we can use this in maximum. We suggest a maximum level of ablation. So when you think that you're activating 4 electrodes to have ablation in 10 points, and if of course that depends on the renal arteries, that will be more effective. On the other hand, there is no difference between right and left based on the bifurcation anatomy we act. And the first question, do we have a response right away? I don't know whether objective or not. Yes, we see certain things. You see that the pressure is decreasing, but it's not acute. So what we want is not to see we have an acute success. We do not have a marker to have this. Mononephrine levels in vivo cannot be measured right now. In the practice, it is not suggested. So our expectation is that blood pressure in the first month and the second trimester to decrease slowly. So this is one of the cases about the denervation. There is a degeneration or not. In the 3 years follow-up, but the blood pressure decreases is stabilized, and in the other presentations that my friends will talk about it. Anatomically speaking, can we see it? Can we say that this patient is benefiting more and this patient is benefiting less? This serious spasm makes us happy. When we say renal artery spasm, it shows that the denervation actually is a good. It's one of the findings. The renal artery spasm we shouldn't be concerned about this. In vitro, so see that there is no dissection, there is no rupture. As I pointed out, there are so many studies that so the rupture and the dissection is very rare. And percutaneously, most of them can be intervened. In our practice, we don't have it, and in the last 5 or 6 years studies, this inspired 10 studies. So in the cases, 2 parts are taken into account: vascular complication. In the big studies is 0. Different from sensitivity study, on match and off match studies. Of course, there needs to be the renal denervation certified experienced people should do that, and this is what has been done in the studies. Can I ask two questions? You said that in the lower GFR patients, there's no problem in the patients, there's no complication, and what is the low GRF, and for the resistant hypertension cases, there is a chronic renal diseases. It is before 45 GFR, lower than 45 GFR. What is the risk assessment in this patient? Any study on this? When you look at the design of the patient, these are the patients that are taken with a normal GFR, HDN on-med and off-med studies. So when we say GFR patient, there are the post-hoc analysis. The GFR is 45 and above and higher than 45, lower and above the 45. And in the basal, when the baseline and the 3 years are compared, these are give similar. So there's a GFR patients with low GFR patients are excluded, and the renal disease patients are excluded in the studies. So thank you very much. I have a question. Thank you very much. So there's a better denervation in the distal bed, so there's a better denervation with the longer catheter technology, but so the denervation, so can be proliferation more than 3 years. Is there an arterial diffuse neurosis can be developed, or vasomedullary renal perfusion can be affected by it? Can you say anything about that? These are very good questions. And when we look at the nephrology, have you heard the question? I think you can hear me. This is a very good question. The kidney is the most important organ. We don't want to have any security concern, but there is no renal artery stenosis. Renal artery stenting is not needed in these patients. Technically speaking, there's endothelial is injured, but in the animal studies, there's renal arteries, endothelial signs are very fast, and the basal lines are corrected, get better in time. So of course, in the animal studies, we see that endothelialization is very high, and there is a lesion cannot be seen there. Thank you very much. I'd like to continue with the second presentation. Sinan Dağdelen talk about renal denervation. Again, he's going to make a presentation. Thank you very much. Can you hear me? We can hear you, sir. In my task, it was written as renal denervation, if I see it right. I was going to talk about the updated activities. I didn't have the chance to talk to Alpay. He generally talk about renal denervation itself, per se. The updated studies are there. I will be talking in a combined manner, and I'll show you the real case. Hypertension is a global problem, so I'll talk about the renal denervation itself, if you allow me, and I'd like to use the time efficiently. Renal denervation in 2008, the first activities started. However, it is 2011 when it is in the market, and we started making renal denervation at the end of 2011. I have a experience of 11 years. So there is a resistant hypertension definition since 2003, and it is made in resistant hypertension cases. But later on, with not only resistant HD hypertension, but there is a systolic and the diastolic hypertension cases. But the beginning of this started with the resistant hypertension. However, the European hypertension consensus is not like this. There is such a definition, but that is not the case in today's world. As I discussed, in the renal arteries, there are the sympathetic nerves, the autonomous nerves through the Schwann sheet, and it is a different. They do not have the myelin sheet. Can be regeneration or fibrosis of the nerves. If there's a motor injury, the regeneration is then done in years. In the autonomous, the Schwann sheet is injured, and through the fibrosis, the regeneration of sheet and myelization is not the case. So so we were concerned whether there will be these nerves again. Not in the in vitro studies, in animal studies, they couldn't regenerate. And of course, with the 3 years, we see that this systolic and diastolic hypotension increases in the exponentially. The gap is increased exponentially. At the end of the 3 years, there's a 5 millimeter mercury decrease is achieved. However, at the end of 3 years, at 12, 13, and 14 and 15, mercury decrease is there. This is because of the successful ablation materials, and as our experiences increase, and when we look at 2012 and 2003, there have been different catheters. There's simplicity flex, the catheters, there's but then there have been many other catheters and line and spirals, or there are other devices, but most of them are in the history right now, and we have 3 of them, and in the practically it is used. There are 3 catheter system. One is the simplicity spiral. The second one is the Record Medical, the Paradise system. This is the high ultrasonographic waves. It ensures ablation, and there are good studies, and the Radiance Solo Chio and Japanese studies with ultrasonic waves, and these are successful. And the pregnant injection, there is the infusion system, and there is the new alcohol-mediated denervation system. It's a sham controlled study as well, and the control group, there have been many important achievements. So in the world, what we use is that this is used in Europe most of the time. We use 80% simplicity spiral. The simplicity spiral catheter has its own design. It opens in a spiral way, and with the 3 and 8 meters, 3 and 8 meters vessel diameter, you can ablate it, and of course the renal accessory renal arteries should be there, and in the 35 to 25 to 30 of the cases, the accessory vessels should be ablated as well. As Akbey pointed out, in the catheter system, we take out it's a spiral, but different from general catheter technique, you never flush it. The electrodes edges can be distorted. So if you say I clean it, if you say this, within a sense, you don't do it and you don't flush this catheter, so you don't clean the edges. You just have it into the connector, and you just shove this and you connect the wire.
You increase the AST of the patient to 250. We use a standard coronary artery for this. We never use anything in other thing. And we place the catheter. And here on the left-hand side, you can see the renal arteries, I-shaped, V-shaped, and Y-shaped main arteries. I-shape represent main and V bifurcation, and Y the distal branches. And at the beginning of 2010, the main arteries were being ablated as in the world. In the later studies, around the main branches, the sheets were seen in carina area, and circumferential ablations were seen to cause greater nerve ablations where sympathetic nerve system increases. Therefore, especially the lobe arteries are ablated. Lobe arteries of 3 millimeters and over must be ablated with patients. When you start this, the main renal artery is ablated at 8 points, starting from the distal one to retrospectively to the aortic exit of the main artery. 8 points are ablated on the right and left side, in total 16 points. And at the moment, we now ablate even 50 points, sometimes even more. As already mentioned, in these patients, when you do the renal Doppler and angiography with low contrast, and if the renal anatomy is appropriate, preps are done, and on both sides you do the renal ablations. And here it is a little bit detailed about impedance and the heating methods. And with this new technique, we use the simplicity renal catheters, 6 FTLG for good work, and simultaneously 4 points can be ablated with minimum 1 catheter. Now let me continue with the cases, and then I will try to answer your questions. First case, 73 years old female, hypertension. Every 2 or 3 months, the tension is controlled, and we increase the medication, prediabetic degenerative aortic valve, and mitral insufficiency. And these are the renal values. In these patients, we, together with nephrologists, are in contact. And the renal functions of these patients may be problematic, and the patients with low YPR are in the safety group. And here, the GFR of the patient is normal, renal functions are normal. In premedication, vasoxam 5 milligram plus amlodipine, perindoprine, and oxazocin were used. But despite this, the tension is high. You can see the ECG of the patient, no pathology. And angiography was done for the patient. And here on the right or left, you can start. It's up to you. And after showing all this, you measure the diameters, you determine the target points, and you enter in these lobes. This is 50% opacified. Unlike coronary, we use this. And then in every artery, we enter into them, you ablate one by one. While doing the ablation, you must be careful about the carina section point. It is not recommended. And after the operation, you do the routine checks of the patient. I think 7 months ago the operation was done. Now these 2 drugs are discontinued for the patient. The first 2 are ongoing, and there is no problem about the tension. Every 2 or 3 days, this patient was coming to us with high tension, but now she only uses 2 drugs, and the tension of the patient is normal. And this is the ECG after the procedure. There is no problem. And of course, during the follow-up of the patients, we also do urine assessment and renal function of the patients. Second case, 60-year-old male, uncontrolled hypertension, continuously coming to the emergency, and diabetic, no serious problem in the coronaries, and AFR arrhythmia, paroxysmal AFR arrhythmia occurs frequently, and we did the renal Doppler was normal. Aortic is a little bit ectatic, left artery is 45 millimeters, renal functions are normal. Before the operation, these are the results. Doxorubicin 8 mg, lecithin 4 mg, furosemide, telmisartan, hydrocortisone are used, and despite these medication, the patient had high tension. You see the former ECG of the patient. We did renal denervation for the patient. All the renal arteries and lobes were ablated one by one, like this. On the left side, we again cleaned the top arteries, ablated them one by one. And during and after the renal artery work, can we see the success? When we do the ablation for this patient, we always do the control. And if you see any notching edema on the walls, this is an indirect indicator of the success of the procedure. But of course, to eliminate a spasm, a low dose of nitrate is administered. During the follow-up of the patient, the renal functions were normal. The protein was positive previously, but this time it's negative. Now, this lecithin was eliminated, furosemide was discontinued. 2 medications left for the patient, and the patient is happy now. She is not coming to the polyclinic every week with high tension. Most important here is to decrease the number of medication and with a stable tension. He or she comes. Thank you very much. If you have any questions, I will be glad to answer. Contributions, questions. Thank you very much, Sinan, for the nice presentation. In these cases, there was alpha blocker and there was no spironolactone. Is there a special reason for this? Spironolactone is not a standard treatment for all the patients, or for these, hydrocortisone or furosemide are given, or adiponate are given, but spironolactone is not preferred. Is a preferred diuretic, but it's not compulsory. To eliminate any wrong message in persistent high tension as a 4th medication, it may be of use, and even there is a study comparing renal denervation and spironolactone, and it is defective. When spironolactone is not contraindicated, it may be useful to try it. I want to make some contributions. 2 or 3 years ago, I wrote a chapter to a book about the doses of the medication, the same group of patients, potence, and whether we can overcome the hypertension or not. And a wide range literature scan was done. Without a potent diuretic, we cannot mention a resistant hypertension, and hydrocortisone, the varying peak point is around 3 to 4 hours. So the only way to overcome this is spironolactone, indoplamide, amlodipine-like potent medication. Secondly, in the first case, for example, yes, there is a group effect in ACE inhibitors, but there is a peak rate. In another study, clomipirone was problematic. Therefore, to decrease the MACE, it was administered in the evening, and if the timid combination was given, resistant hypertension wouldn't be in question for these patients. So the final target is the treatment of direct hypertension or resistant hypertension. So your purpose was to target the hypertension directly. Yes, at the very beginning, these patients were selected in HTL1 and 2 studies, and one of the criteria was the resistant hypertension. And in these patients, in 2021, in June, during the sham control, the European Hypertension Society published a consensus report, and in that report, the hypertension treatment was shown to be not compliant with the resistant hypertension treatment. Therefore, to use a device treatment for the patients, there must be a consensus of the local hypertension society. And in these patients, if the patient is not non-compliant, and if there is imbalanced tension, because these patients are suffering from this hypertension for a long time, and many medication alternatives were used, and due to drug intolerance, we had to change some of the medication. And the final treatments were the latest medication prescribed for the patients. And the drugs that you saw in the lists were not the only option for the patients. They used many medication combinations. Some were discontinued for various reasons, and many combinations were already used until coming to this point. Not just 1 or 2 medication. In these patients, you cannot use any dose or any medication due to medication intolerance. So the medication I used here were before denervation. Do you use emulator blood pressure? Yes, we do. In these patients, before we do the blood pressure control, before the denervation, because intolerance and non-compliance are indicated with this. This is one of the criteria. I mean, if you cannot achieve what you want with the medication, and despite the control every other day or every 3 days, these patients come to the polyclinic with high tension. When you use a few drugs and you cannot regulate the tension, you do not do the renal denervation once. Is there a complication of this? With the experiences in this treatment and the conditions of the treatment also change. In PTM1 and 2, and in the first training programs, if the renal artery plaque is 30% and over, denervation was not recommended. But today, with the conditions and acceptance, if there is 30% or over plaque in the renal artery, then you need to ablate around 1 centimeter. This is the current condition. Only the plaque point is not done. The ablation is not ablated. About cardiac insufficiency, do you have updated data? Well, I wonder one thing. I think everyone there has an experience of cardiology more than 10 years. And as far as we know, within class 1A, there are beta blockers. In atrial fibrillation and arrhythmia, there are beta blockers. In aortic aneurysm, we use beta blockers. In coronary artery disease, we again use beta blockers. Why do we use it? Or in general, we use beta blockers in tachycardia, hypertension. And within cardiology, there are many diseases, and in all of treatments, we use beta blockers because we want a chemical symptomatic effect, and chemically, in order to synthesize the receptors, we want to block the hyperadrenergic region, hyperadrenergic damage through symptomatic treatment. This is. And for cardiac insufficiency, there are minor studies, subgroup studies for cardiac insufficiency. Only cardiac insufficiency is not indicated for renal denervation, but is one of the important plans in the future of the renal denervation. We will see it. I was going to mention about this actually, this Abness syndrome and in arrhythmia. And there will be an indication for this. And in these patients, in even insulin resistance, the efficiencies and advantages of this will be seen. In subgroup analysis, we already see there are such studies. And if I was given this topic, I would talk about it for an hour. Especially in the selected patient group, it would be of use, but we need to select the patients in a diligent manner. If there is a secondary hypertension, we shouldn't ignore these patients again. If there is a systolic hypertension, we should be careful about it. Sympathetic activity is high, cardiac is high. These patients will benefit more. And therefore, with a good patient selection, especially with this distal ablation, the rest system and adrenergic system will be benefiting from this. With the suitable patients, a suitable indication may be chosen. We need to define the correct patient again. Is there any patient profile that you predict? No. The definition of resistant hypertension is not merging together with renal denervation, and it exists with the first declarations. And with the first studies, it was said that let's use it with renal the resistant hypertension. Only these people working in this planned this. But in the later studies and in the course of the literature, in Hypertension 1, 2, 3 studies, in spiral offlet studies and other studies, both the systolic hypertension and diastolic hypertension patients were involved in the studies. And the event was seen to be more beneficial for this. And finally, the European Hypertension Society published a declaration, and in that paper, in order to do a device treatment for the hypertension, it shouldn't be resistant hypertension. There is not such a definition. We use this medication, and this medication is not the case. There is the terminology of diuretic, and it's also a general one. Some colleagues use certain ones, but diuretic is a general concept. For example, triamterene is used for a patient and intermediate for another patient. In 2024, the European Society will renovate their guidelines about the device treatments. Important, most probably, in 2B classification, it will be involved. You will see this definition and the general diuretic concept, but use spironolactone is not in question. Such a generalization is not done, and even the diuretic terminology may be omitted. Thank you very much. One last question from the hall. Thank you very much for your presentations. About carbon monoxide angiography, what do you think for patients with high creatinine? Yes, it can be used for the renals in active organs. Carbon dioxide angiography is not used, but in peripheral procedures, we sometimes use it. In renal, we can use. In renal patients, we do it under anesthesia because it's painful. We use pentanate, but you need to make an apnesis there to ensure the stability. Yes, you can use it for renal patients. We also use it in peripheral patients. And seriously, it decreases the contraction. It's very effective in selected patients. Thank you very much, Sinan. We will continue with the last presentation by Ms. Paolo. Hi, everyone. I think this will be the last presentation of the day. This is an issue you already know. Up-to-date treatments in hypertension. I reviewed the latest guidelines, and most of the time I depended on the Turkish Hypertension Consensus Report, and there is also another guideline, International Society of Hypertension, which was published in 2020, and I generally refer to Turkish Hypertension Consensus Report. There are some differences, but generally they agree. The hypertension definition was updated in 2017 by the American Cardiology Society, and the limit was decreased, and for hypertension 130 systole and diastole was around 80, but this is a very claiming terminology. In sprint study, the people with systolic blood pressure of 120 were compared to 140, and in the intensive treatment group, less cardiovascular mortality was detected. And there were some oppositions to this because in this study, the automatized non-accompanied automatic measurements were used. In such blood pressure measurements, certain degrees were lower, and the blood pressure is taken as a lower reference point. Therefore, some societies do not consider it suitable. And then the European guidelines were published, and in classical terms, the in systolic 140 and in diastolic 90 were accepted as the threshold. And the Turkish Hypertension Consensus Report was updated in 2019, basing on the previous guidelines. And again, 140 and 90 were the reference points. And in systole and diastole, the 80 to 90 range was the increased tension. As for the non-clinical blood pressure measurements and hypertension diagnosis, at home, 135 or 85. More than this is as a hypertension, and at the ambulatory measurements, 130 or 80 is the 24 hours average. And it is the threshold for the hypertension. Now, what do we encounter with a high blood pressure measurement? For the systolic blood pressure, 140 to 160, and for the diastole, 100 to 110. We need to wait for 2 to 4 weeks, and we must repeat the measurements. We must change the lifestyle, and if still, despite these changes and measurements, within 2 or 4 weeks, if the blood pressure is still over 140, then hypertension is the diagnosis. And shorter waiting periods are in question for the diastolic. For the if we see the measurements within these ranges within 1 or 2 weeks, we diagnose the patient as hypertension. If the systolic blood pressure is more than 180 and the diastolic is 110, we immediately diagnose the patient as hypertension. The lifestyle changes include ideal body weight, decreasing the salt healthy diet, quitting smoking, restricting or quitting alcohol, and and eating fruits and vegetables, low fat dairy products, being away from red meat and carbohydrates, and stress management. And about the diets, caffeine and pomegranate juice are also among the recommendations. Quitting smoking, restricting alcohol, a dynamic life, 5 times exercise, minimum 30 minutes a day, independent on the weight loss, helps to control the blood pressure. An ideal weight is around causes a decrease of 1 millimeter in the blood pressure.
Potassium, there should be potassium excess in the food, and in food there could be supplements with potassium. Potassium has a decrease. It's not there, but if there's a hypopotassiemia, if not, that's not the case in the patient, we can recommend potassium, and the alcohol should be limited, as we mentioned. In hypertension, when we look at the medical pharmacologic treatment and approach, in 100 system, so we can say that this is increased hypertension if this is 130 and 84 and 89. There is lifestyle changes in the 6 months. If there is a lifestyle change in 6 months, if we are in the same page, and if there is a higher cardiovascular risk for this patient, medical treatment can be recommended to this patient. Another group, it's the stage 1 hypertension, and there could be the lifestyle changes are important in these patients, and 3 months of lifestyle changes is targeted here. And if there is if we cannot decrease the high blood pressure, there is the pharmacologic treatment. You can start directly with the medical risk if there's a diabetes risk, if there's a kidney disease, or if there's a cardiovascular disease for this patient. For the 450 the medical treatment can be started in this patient. With this change, and there's if it is more than 160, the medical treatment should be started. And the pharmacologic treatment, there is the angiotensin receptor blockers, ACE inhibitors, and also angiotensin receptor blockers, RNBs, and calcium channel blockers, and the diuretics. These groups are in the primary hypertension treatment. If not, if there is not enough response for the treatment, and if there's in the special indications, beta blockers, alpha blockers, potassium diuretics, and central agents can be added to treatment. And combination treatment is important. I'll talk about mono treatment as well, but in the last guidelines as well, combined treatment is there, and combined treatment, we see that if you cannot achieve, if it is 20/10 mercury, we recommend this. It's a potent effect And to have the monotreatment side effects are the side effects than the monotreatment is lower than this. And in antihypertensive pharmacological treatment in stage 1, if it is below 190, we give monotherapy. However, in the latest guidelines, rather than the monotherapy, there is a combined treatment of half doses, and this could be the full dose combined treatment, and three drugs combined with this. I will not touch upon monotherapy very much. And for the stage 2 hypertensive patient, we start with the combination. It's recommended to start with the recommendation therapy, and the combinations are RAS system, RAS ACE inhibitors, or angiotensin receptor blockers, and together with that, and calcium canal blockers. And we see that the European group is recommended. ACE, RAB, and diuretic use combination is in the secondary use. And if we fail in this combination, we can add diuretics. And although there's a diuretic, and if we still fail, so as discussed in the spironolactone can be added to the treatment as a fourth medication. And in uncomplicated hypertension pharmacological strategy, in the starting treatment, there is a combination of two drugs. I told you which groups, and calcium channel blockers. In the second stage, if there's a third combination, there's a diuretic should be added if it is not enough. And the third one, there is the patient is given the resistant hypertension, spironolactone, 25 to 15 mg per day should be added to treatment. But if we can add other treatment options, if there is a hypertension problem in the patient, these combinations are used in the last treatment combination, spironolactone, or the other groups can be added. What is the beta blockers? As if there's a heart failure, coronary artery disease, atrial fibrillation, or the patients with the pregnancy plan, beta blockers can be added in every stage of the treatment. In coronary artery disease, different from the others, a beta blocker can be used in the treatment. In chronic renal disease patients, there should be in terms of progression, ACE inhibitors or RAS blockers have an important place in the upcoming stages. If there's hypovolemia development in the patient, diuretics and the precedent can be added to the treatment. You say the target values based on the different ages and age groups for uncompleted below 190. Be a target 120 and 30. If it is a low, advanced age, this increases. It is at 132 and more, and above all this, for the systolic, we can have it. And in the chronic artery patients, if there's a high risk group, so the threshold values can be taken lower, and we can decrease the blood pressure. And the guideline, and we see the target pressure values. These are the recommendations of European Society, which are similar. And if we are talking about the contraindications for diuretics, we know that it cannot be given in gut disease. And for the heater of pills, they do not have a contraindication. If there's a block risk, we don't use it. And ACE inhibitors, pregnancy, and pregnancy for RAB, for stenosis. In the ACE inhibitors, different angioneuritic edema is there, we don't use it. And for beta blockers, for the non-selective ones, asthma is the strict general contraindication. We don't use it on AV block. And beta blockers and angiotensin in terms of block, and there's the heart attack risk, and we have to follow this patient. Should we give the medications in the morning or in the evening? There are some publications showing that the cardiovascular risk is decreased as it is given in the evening. It decreases the hypertension more. But so this is not very clear. And so last but not least, hypertension in the pregnancy, and it should be 449 mmHg should be the target value in the hypertension diagnosis. And the threshold of the treatment, we don't rush it. It is 195 millimeters. Mercury should be more than that. In the treatment, there are not many studies, and we need to look at the drug effects on the patient. Calcium channel blockers, Nisadafen can be used. Beta blockers, alpha metyl dopa can be used in this patient. In the diuretics, it's not recommended. In the lactation, it is similar. Denervation can be in the lactation. Alpha metyl is related to postpartum depression, and other hypertensions can be used in the lactation. So as we had a limited time, I wanted to explain the presentation in a short manner. Thank you very much for your very nice presentation. I'd like to ask you a question in the GFR low patients. As a nephrologist, what is at the ACE levels? So if it is, what should we do in the in terms of nephrologic perspective, what can you say? Potassium is important. Potassium 4.5. If it is not more than that, we do not refrain from giving these drugs if we can follow the patient closely. It's beneficial for the prevention of progression to the kidneys if we can follow the patient up there. So any questions from the panel or any questions from the hall? So can we say that for the patients in dialysis and so in KBH patients, we can give ACE inhibitor if there's no potassium problem? I give it in my daily practice if we can just follow the patient. And of course, if the GFR is 10 or 18, if there's the limit of the patient, so if I do not have the renal tissue, I do not take any risks. I do not push the patient or myself for days. We have to think of protecting the heart. You're right. Yeah, from that perspective, you're right. In terms of ASC, ACE, can you say that this ACE is better and this is not better? For example, like the uric acids and everything. I don't have a preference, but I agree with the potassium. It's under the RAS blockers, ACA and RAB, and of course we need to look at the cessation of the patients or patients quitting the drugs. For ACA, so there's more dissatisfaction in the patients, and we can say that on the other hand, the potassium is an important parameter, and in nephrology and in cardiology guidelines, so the RAS blockage use the prevention as potassium. We want to use this, but this is a risk. How do we have the risk? And there are the new approaches. In my daily practice, if I can look at follow the patient up, if it is 5.5 and the youngsters, I'll look at these. So whether they will be in the line of a diet or from metabolic acidosis. So in the hypertension struggle, if there is a venous carbonate level, it should be 20 to 22, between 20 and 22, and if there is a carbonate,